Welcome to Marrow Masters, sponsored by the National Bone Marrow Transplant Link, Seattle Genetics, and our esteemed link partners. The National Bone Marrow Transplant Link, established in 1992, strives to help patients, caregivers, and families cope with the psychosocial challenges of bone marrow stem cell transplant from diagnosis through survivorship. This season will focus on busting marrow myths. There are many myths related to transplant. Am I too old for a transplant? Are clinical trials exploratory and dangerous? My chronic GVHD will never end. Or will it? Does palliative care mean hospice? Is our love enough to get us through this cancer? No match in my family. Am I out of options? And timely info on CAR T cellular therapy as it relates to transplant as another option. Here's the host of Marrow Masters, the Executive Director of the National Bone Marrow Transplant Link, Peggy Burkhardt.
Welcome to Marrow Masters. It's time to bust another myth. I do not have a match in my family. Am I out of options? First, I'd like to introduce our expert speaker today, Dr. Effie Petersdorf, who is here to help us with this one. Dr. Effie Petersdorf is a professor of medicine at the University of Washington and Fred Hutchinson Research Center in Seattle, where she treats patients with blood cancers using stem cell transplantation. Dr. Petersdorf's area of expertise is in the genetics of transplantation. She was recognized by President Clinton for her research contributions to the field, as well as by numerous national and international societies. Dr. Petersdorf has served as president of the World Marrow Donor Association and the American Society for Blood and Marrow Transplantation. Welcome, Dr. Effie.
Well, hello. Thanks for inviting me. To answer your question, I don't have a match in my family. Am I out of options? The answer is absolutely not. You know, Peggy, when allogeneic transplantation was developed decades ago, we started with the use of matched brothers or sisters in the family. And this is because we knew from the beginning that it was really important for the patient and the stem cell donor to share the same tissue type, also called HLA, because the better the match between the patient and the transplant donor, the lower the complication rate after transplantation. But since those first transplants were performed so many years ago, there's been significant progress in making the transplant safer. And in fact, now, donors can be either family members or individuals not even related to the patient.
Dr. Effie, could you give us some background regarding HLA tissue types?
Yes, HLA are proteins that play a really important role in our immune system. So, for example, they help us fight infections, say from viruses or bacteria, because they're at the front line of the immune system trying to protect us and keep us healthy. So in a transplant, the immune system cells use these HLA proteins to also survey for anything that looks different from oneself, anything that looks foreign, including the graft from a donor in a transplant. So that when we do a transplant, the patient's immune system, if it sees the donor as being different than himself or herself, the patient's immune system has a chance of fighting against that donor and eliminating that graft. By the same token, when that donor's stem cells circulate in the patient's body, the donor's stem cells are educated to keep that donor safe. And to the donor, the patient is foreign, and the donor's stem cells may then fight against the patient. We know that the HLA matching is so important because if the patient and the donor are really well matched, it will cut down on the risks of the patient rejecting the donor, as well as the donor fighting against the patient. Now, the reason why unrelated individuals can serve as donors for a stem cell transplant is because of the HLA tissue type. These are proteins that are shared across people the world over, and that's why even though a patient may not have a match within the family, we can actually identify very well-matched donors who may live very far away from the patient. So the proteins that govern how well a graft is accepted by the patient and the same proteins govern whether or not the donor is likely to see the patient as different are called the HLA tissue type proteins. So a lot of people think that the tissue type is the same as the blood type, but in fact, they're completely different proteins. blood type, as you may know, comes in 3 different forms, A, B, and O. But the tissue type, or the HLA type, is much more diverse, and there are many, many different proteins that we have to match for. So in a given family with a biological father and a biological mother and full brothers or sisters, the chance that any one sibling is a complete match with the patient is 25%, because that brother or sister just so happened to have inherited exactly the same tissue type from the father and mother as the patient. The chance that any one sibling is a complete mismatch is 25%, and the chance that any one sibling is half-matched is 50%. So this is how it works. We have inherited half of our DNA from our biological father and the other half from our biological mother. So in a complete match, the patient and siblings have inherited exactly the same HLA from the father and mother. When a sibling is completely tissue type mismatch, they just happen to have inherited the opposite HLAs from the parents. And then when a sibling is half matched, then they share one HLA from one parent, but they inherit the opposite HLA from the other parent. And another name that you might hear for half-matched brother or sister is haploidentical. So we differentiate between a complete match, a haploidentical match, and a complete mismatch. You can imagine that if the family is a large one, there are more opportunities that there might be even one match in the family, but it doesn't mean that having a large family is absolutely a guarantee that the patient will have a match.
As I understand it, transplantation was originally developed for completely matched siblings because of the potential for 2 different complications. One called graft rejection, and the second, graft versus host disease, also known as GVHD. Dr. Effie, can you please elaborate on this?
Yes. Graft rejection happens when the patient sees the transplanted donor stem cells as being different from where they came from. And so the patient's immune system's natural defense is to try to get rid of a foreign invader. And all the patient's immune system recognizes is that the donor looks foreign. So this is called graft rejection. And this is what we want to try to avoid, because we're highly dependent upon the donor graft to take and become the patient's new healthy immune system. Now, the flip side of graft rejection is called graft versus host disease. And this is a potentially severe complication of the transplant and happens when the donor stem cells have engrafted in the patient's marrow space. And then those stem cells are released into the blood and start circulating. And again, those donor stem cells are trained to protect the donor against things that are different. And all the donor stem cells know is that they're in a different body, the patient's body. So the donor stem cells have the potential to mount an attack, so to speak, on the patient's body. And this can take the form of a skin rash or nausea or vomiting or inflammation of the colon. Now, GVHD can have different grades or severity, and sometimes graft versus host disease is so mild that a patient doesn't even need treatment. But sometimes it can be severe and even life-threatening. And in those instances, we want to make absolutely sure that we can give immunosuppressive therapy to calm down the inflammation or the attack. So the tissue type matching that we do when we choose a donor, whether it's a donor from the family or a donor outside of the family, is to try to match these HLA tissue type proteins, because the better the match, the lower the risk for both the graft rejection as well as the GVHD complication.
So what role do immunosuppressive drugs play?
So we rely very much on immunosuppressive drugs to calm down the immune system. So what we want to do is make sure that the donor graft takes and is able to produce nice and healthy stem cells that become the patient's new immune system. So the patient receives different types of immunosuppressive therapy in the form of radiation, with chemotherapy, and different sorts of combinations, as well as immunosuppressive drugs to allow the stem cell graft to take. By the same token, these immunosuppressive drugs calm down any attack or inflammation that is potentially involved when the graft sees the patient as being different. So the transplant is safely performed by using these immunosuppressive drugs to allow the graft to take and to prevent the very severe form of graft versus host disease in the patient. So there are lots of steps that we take when we know that there's not a match in the family. And now we have very large registries of volunteer donors and cord blood units, both of which can be used and considered as possible stem cell sources when the patient needs a transplant but doesn't have a match in the family. It's been so gratifying to see that there has been a tremendous response to the need for unrelated donors for transplants worldwide. So, for example, in 2018, there were over 35 million donors registered and over 750,000 cord blood units that have been collected and frozen in cord blood banks and repositories all around the world. So if a patient is in need of a stem cell transplant to cure their blood disorder and does not have a suitable family member to serve as a donor, then the patient's HLA tissue type is entered into a computer system which connects all the tissue types of the volunteer donors and cord blood units available the world over. And what transplant centers will do is they will try to match up the patient's tissue type with that of the donors or cord blood units and try to identify the best possible donor or cord blood unit possible, no matter where that donor resides or where that frozen cord blood unit is. There are usually 5 HLA tissue type genes that transplant centers will try very hard to match the patient to. These genes have specific names such as HLA-A or HLA-B or HLA-DR. A lot of transplant centers try to match for 5 genes, and some transplant centers are trying to match for a 6th gene called HLA-DP.
Dr. Effie, we hear about a donor being a 10 out of 10. What does that mean, and how common is that?
A 10 of 10 matched donor means that the patient and donor have exactly the same tissue type at 5 different HLA genes, because everybody inherits half from their mother and half from their father. We each have 2 HLA proteins at each gene. So if you have 5 genes, we're matching for 10 total HLA proteins. So a 10 out of 10 match means that all 10 proteins at these 5 genes are exactly the same in the patient and the donor. Now, sometimes we can't find a perfect match. The chances of finding a perfect match really depend on how common or how rare the patient's tissue type is. It also depends on how many donors are registered, and it depends on the ancestry of the patient as well as the ancestry of the donor pool. So there's some patients that have a much higher chance of finding a 10 of 10 match than others. And when we can't find a perfect match, then sometimes we do allow donors with one mismatch. When you have a donor with one HLA tissue type mismatch, that's sometimes called a 9 of 10 match because you're only off by 1. So in answer to your question, Peggy, the success rate of finding matched donors really depends on how common the patient's HLA tissue type is and how large and ethnically diverse the donor pool is. If a perfectly matched, unrelated volunteer donor cannot be identified, then sometimes we look at the cord blood units. Because in fact, there's less stringent matching required for finding a cord blood unit. That's because we think that the cord blood stem cells are very young and naive, and they don't lead to as high of an incidence of the graft versus host disease as stem cells from adult volunteer donors. So to put it in other words, patients might tolerate more HLA tissue type mismatching with cord blood units than with adult volunteer donors. So what happens is after a suitable volunteer donor or cord blood units have been identified by the transplant center on the search, then the patient is readied for the transplant at the transplant center. If an unrelated donor transplant is being coordinated, the donor might live very far away from the transplant center, and the donor always remains anonymous to both the treating team and the patient. So during the time that the patient is getting ready for his or her transplant, the donor is also readied to donate the stem cells in his or her own hometown. And then the stem cells are transported to the transplant center and timed exactly when the patient is ready to receive those stem cells on the transplant date.
Dr. Effie, can I ask also, what is involved in delivering a cord blood transplant?
In the same way that we coordinate an unrelated donor transplant, we ready the patient at the transplant center by giving the patient certain types of chemotherapy with or without radiation. The cord blood units were previously collected at birth and frozen. So before we get started at the transplant center, those cord blood units are shipped to the transplant center, and they are readied so when the day comes for the patient to receive the infusion of the cord blood stem cells, they are ready to be infused into the patient. So no matter if the donor is a volunteer donor where the collection of the stem cells actually happens in real time, or use of frozen cord blood stem cells that were previously frozen at the birth of the baby, it's all coordinated to coincide with the treatment that the patient is receiving at the transplant center, and both stem cell grafts are provided to the patient on the patient's transplant day.
Dr. Effie, can you share with us a patient story?
Well, I would love to share a story of one of my patients who needed a transplant to cure her leukemia. After she learned that none of her brothers or sisters were a close match, we started a search for a volunteer unrelated donor. And we were matching for 5 genes as a basic matching algorithm. But not only did we find a 10 out of 10 matched unrelated donor, we were even able to match for the 6th gene, and she had a transplant from an unrelated donor that was a 12 out of 12 match, which made us incredibly happy that we were able to provide an incredibly well-matched donor for her transplant. So even if a patient doesn't have a matched brother or sister, definitely using a matched or mismatched unrelated or cord blood, and even with the newer procedure of using a haploidentical sibling, can all be feasible. So even if one doesn't have a match in the family, there are options.
And how is this patient doing today?
She's doing very well.
Oh, that's so wonderful. Is there anything else you want to add at this point, Dr. Effie? We so appreciate you helping us out today as we bust another myth.
It's just been such a great pleasure speaking with you today, and I just wanted to let patients and family members know that there are always resources that they can go to find out more information about how we find and select donors both within the family as well as across unrelated donor registries and cord blood banks worldwide. Our registry here in the United States is the Be the Match Registry, and they have a wealth of information for patients and family members as well as donors. In addition, the World Marrow Donor Association has a really good website that one can go to for more information on the use of international unrelated donors and cord blood units that are shipped worldwide across international borders, no matter where the patient lives. So there are always options.
Thank you again, Dr. Effie, for helping us out as we bust another myth. We sure appreciate your time.
Thank you for the invitation.
This has been the Marrow Masters Podcast. Feel free to share this episode via social media, text, or email. To hear more, subscribe for free to Marrow Masters in your favorite podcast app. To learn more about the resources available to patients and caregivers, check out the National Bone Marrow Transplant link at nbmtlink.org. That's nbmtlink.org, or just tap the link below in the show notes.